Welcome to our session. Just to remind you that Gecko is hosted locally by the GastroFoundation in association with Project Echo from the University of New Mexico. We've got sessions like these every Wednesday. We rotate through some adults, GRT, some hepatology, and then every so often it's pediatrics turn like it is today. So today I'm very pleased to be able to welcome Nirav Patel to this platform. He is one of our pediatric surgeons at the Chris Hanna Baragwanath Hospital, and he has taken time out of his extremely busy day. He was telling us that it's burn season at the moment, so unfortunately a lot of children with burns in the wards at Barra at the moment. So we're thankful for his time, and we hope he doesn't get cold in the middle of this talk. And we're going to discuss really the surgical aspects of portal hypertension and shunt surgery. So to me, we see a reasonable number of portal hypertension children in our practice as gastroenterologists, and they're really usually due to cirrhosis. And shunt surgery, I'm sure Nirav is going to tell us, has got a limited role in many of these patients. But there are some that we do want to discuss with Nirav and his colleagues. And what I want to do is I want to start off by sharing a very short case. And let me just get that in full mode. I hope you can see that.
Yes, we can.
Thanks, Cheryl. So this is a 7-year-old male, and I have to say this is one of several patients that we still see from the more rural areas of our country who presented with veno-occlusive disease. So his liver biopsy confirmed hepatic sinusoidal obstruction syndrome. Mom said he was given traditional medication for a while before presentation. And unfortunately, he ended up with portal hypertension. He was referred to us last year, and we scoped him soon after making the diagnosis. We found grade 3 varices. We found some portal gastropathy. We banded the varices and started him on medical prophylaxis, and then asked him to come back in a few months' time for a repeat scope. So once again, in January, he had grade 3 esophageal varices. We banded again. And then it took a while for us to see him again. But we continued medical management. And in May, we re-scoped him and saw that he had grade 3 varices again. But he now also had gastric varices. So we're not winning with our endoscopic measures. We're not winning with our medical measures. And when we look at his liver synthetic function and his liver reserve, he's really not doing too badly. He's got a PELD score of -5. He also doesn't have hypersplenism. His platelet count is normal. So we know that our surgeons are going to ask for a CT angio, a triple phase, and this scan was done on this child. This is representing the splenic vein on your middle right, I guess, running all the way across into portal confluence, and you see a bit of his right portal vein. The left portal vein you could see on another cut. Everything was patent. And what you can also start to see here is a few dots higher up just above the stomach, between the spleen and the stomach, and those are actually the gastric varices that he was forming. This is a cut slightly lower down just to show you the renal veins, because just to show that those are also patent, and these are different shots. The left higher up showing a varix at the top of the stomach almost, and lower down you can actually see periumbilical varices as well, and many mesenteric varices. So he's got severe variceal disease, which we're struggling to control. His portal vein is patent, his splenic vein is patent, not shown. His RVC and hepatic veins are patent. And we're wondering if this would be a candidate for a non-physiologic shunt. So with that question, I want to stop sharing and hand over to Nirav, and maybe we can come back to the patient later on. I realized I forgot to tell you that we do have the chat open for questions, and or raise your hand afterwards and we can address your questions. Thanks, Nirav. We can see that great.
Cool. Thanks, Tim. Thanks, everyone. My name is Nirav. I'm a pediatric surgeon at Barra. I'll just speak about portal hypertension, the different shunts that we can do, and what are the indications for those shunts. So we know that portal hypertension is not that uncommon problem in our environment. It's defined as a portal venous pressure gradient greater than 5 millimeters. So essentially the difference in the pressure gradient between the hepatic sinusoid and the hepatic vein needs to be greater than 5 millimeters, or you need to have a portal pressure that's over 10 millimeters of mercury, and then you can say that the patient has portal hypertension. The pressure in the portal system is low because of the high compliance and the low resistance in the system. So it's difficult to say exactly when it becomes clinically relevant. Some sources say 10 millimeters of mercury, some sources say 12 millimeters of mercury, but we generally use 10 millimeters of mercury as the cutoff because that's when you start seeing the varices, and this is in adults and in children. So the important things to know are that, we define it as a hepatic venous pressure gradient of more than 5 millimeters of mercury, and that the normal pressure in the portal system is low because of the high compliance and the low resistance, and that clinically portal hypertension only really becomes relevant when the pressure in the portal system is more than 10 millimeters of mercury. There's many different ways in which you can classify portal hypertension, but we mustn't try and make it too complicated. We'll just try and make it as simple as possible. So portal hypertension either develops because you have hepatocellular disease with liver fibrosis, or you have a primary vascular abnormality. And either one of those things can exist by itself or in conjunction or together. And essentially what they end up resulting in is either an increase in flow through the portal system, an increase in resistance in the portal system, or both of those in combination. And so, you can really think about it however you like, but if you understand that, then you can understand portal hypertension, and you can sort of understand the surgeries to treat it a little bit better. You can think of classifying portal hypertension in many different ways, and the easiest way to think about it is prehepatic, hepatic, and post-hepatic. And when you classify it like this, it helps you to understand what are the different causes and what are the different treatment options for those different causes. Within the liver, you can think of portal hypertension as occurring before the sinusoid, at the sinusoid, or after the sinusoid. But it doesn't matter really how you think about it. The most important thing to remember is that really the portal hypertension exists because of an increase in resistance to flow, an increase in flow, or a combination of both. And when you classify it as either prehepatic, hepatic, or post-hepatic, you're just looking for the underlying etiology that may be causing the problem. So, portal hypertension can present in many different ways. We all know that patients present with splenomegaly, hypersplenism, evidence of portopulmonary syndromes, portal gastropathy, portal biliopathy, ascites, encephalopathy, and all of those things. But really, 2/3 of patients with portal hypertension, particularly in our experience, 2/3 of patients will present with splenomegaly and hypersplenism and upper GI bleed. And we really consider the constellation of a variceal upper GI bleed and splenomegaly to be pathognomonic for portal hypertension. So those are the two things we're really worried about: splenomegaly and a variceal upper GI bleed. So if you want to understand the different options that are available for shunt surgery, it's really important to understand this diagram. So it's a very simplified diagram, but it doesn't really need to be more complicated than this. So we know that the portal vein, the main portal vein, is formed by the confluence of the superior mesenteric vein and the splenic vein. We also know that an important tributary for the splenic vein or the portal vein are the left gastric, which is the coronary vein, and the inferior mesenteric veins. So if you understand this, then you can really kind of get a better idea of what are the different surgical options for the management of portal hypertension. So, in the literature, you can find a lot of sources that say that up to 15% of patients, pediatric patients with portal hypertension will require shunt surgery. I mean, that's certainly not been my experience because we've done, a handful of shunts in the past few years for children with portal hypertension. And I think that the advent of endoscopy and the medical management of portal hypertension with the use of beta blockers has really moved people away, or moved us away from needing to do shunt surgery as an emergency. And now we only really use it as a surgical option in elective management of portal hypertension, and really in very specific instances. So there are several different indications for shunt surgery in patients with portal hypertension. And I think it's important to list them and actually just talk about them a little bit. The first one is an isolated extrahepatic portal vein obstruction. So that's where there's no intrinsic liver disease and your portal vein is thrombosed. I mean, this is the most common type of portal hypertension that we see outside of patients with intrinsic liver disease. And usually it's patients that had either a history of encephalitis as neonates or patients that had previous umbilical vein catheterization. There are some patients that develop this extrahepatic portal vein obstruction, so essentially portal vein thrombosis because of coagulopathies, but they're also in the minority. The other indications for shunt surgery in portal hypertension are patients that have a very poor response to the medical and endoscopic management of their varices, those that have bleeding gastric or ectopic varices, those that are managed for their portal hypertension medically and endoscopically, but still have either significant hypersplenism or splenomegaly, those with a symptomatic biliopathy, and also, in some places of the world, they don't have access to endoscopy. So those are the different reasons to consider shunt surgery in children with portal hypertension. When you're trying to work someone up for a shunt in portal hypertension, you essentially need to know three things. What's the cause of the portal hypertension? What's the anatomy of the portal tree? And what's the hepatic reserve? And if you can answer these three things, then you can understand whether a shunt is, number one, appropriate, and number two, if it is appropriate and indicated, then what is the appropriate shunt for the patient? So I'm not sure if you guys have seen this diagram before, but it lays it out so nicely, actually. I mean, I know that it's not a definitive management algorithm, but it is actually quite revealing. So in a patient with intrinsic liver disease and poor liver function, there's no actual surgical shunt except the TIPS, which is a temporary shunt that is a viable management option for this child. This patient needs liver transplantation. In a patient with intrinsic liver disease with good hepatic reserve that then has either failed the medical management and the endoscopic management or has some other reason why a shunt is indicated, then shunt surgery becomes an option. In those patients with extrahepatic portal vein obstruction, then as long as the patient has a patent left portal vein, shunt surgery is actually curative for the patient because they have no intrinsic liver disease. And by bypassing the extrahepatic obstruction, you're actually resolving all of the problems that the patient has. And then finally, in patients with outflow obstruction, so either Budd-Chiari or veno-occlusive disease, you do have the option in patients with some reserve to do a total portosystemic shunt. But in those without reserve, I mean, again, transplant is something that you need to think about. So when you want to classify shunt surgery, I mean, essentially, you're going to think about them in three ways. I changed the slide, so I apologize. There's one thing that's missing here. So it says selective and non-selective shunts, which is very important. But there's something here that says that's missing that's supposed to say physiological. So essentially, you have three types of shunts. You have non-selective, selective, and physiological. So the non-selective shunts are shunts that are aimed just to decrease portal pressures. They're not aimed at decreasing the pressure within a specific compartment. And you can either have the total version of that shunt or the partial version of that shunt. And the only difference between the two is actually the amount of blood that gets diverted. So in the total non-selective portosystemic shunt, you have a massive diversion of blood away from the liver back into the systemic circulation. So the hepatopetal flow, the flow towards the liver, is dramatically reduced. So obviously that's going to result in a massive decrease in pressure in the portal system. So you're going to get quite substantial relief of like bleeding from varices, but it's also going to result in other complications. Because you're completely bypassing the liver, you're at a higher risk of developing encephalopathy. One way to try and mitigate this is by doing what's called a partial shunt. So it's a partial non-selective shunt, so that all of the blood is not diverted away from the liver into the systemic circulation. The other types of shunts that we have are the selective portosystemic shunt, the distal splenorenal shunt, otherwise known as the Dean-Warren shunt. And the reason that it's selective is because you're not decompressing the entire portal system. What you're doing is decompressing one compartment or one piece of that portal system. And then finally, what's not written here is the mesorex bypass, which is a completely physiological shunt. So if you go back to the diagram that I had put up a little bit earlier, and just look at it, and just think of it in the way that a plumber would think of it. The Dean-Warren shunt is a shunt that we use when we only want to decompress the stomach and the spleen. The other non-selective, so that's a selective portosystemic shunt. The other non-selective shunts are shunts that almost completely result in a diversion of blood flow away from the liver into the systemic circulation. And then finally, we have the mesorex shunt, where you bypass the obstructed extrahepatic portal vein and divert the flow through the bypass conduit back into the liver via the left portal vein. So the first thing to discuss is this Warren shunt, or the Dean-Warren shunt. And essentially what you're doing is you're decompressing the stomach and the spleen. And what you essentially do is ligate that left coronary vein, or the left gastric vein, ligate and divide the splenic vein, and then perform an anastomosis between the splenic vein and the left renal vein. And in accomplishing that, or in achieving that, you've got a partial decrease in the portal pressure, because you've diverted that stomach, esophagus, and spleen away from the portal vein into the systemic circulation. But you still maintain some hepatopetal flow via the superior mesenteric vein and the inferior mesenteric vein. The shunt was described about 30 or 40 years ago, and it is relatively well tolerated. And certainly in our experience, it's been the one that we've done the most frequently. Even in cases where patients just have extrahepatic portal vein obstruction. But again, it's only appropriate in patients with a hepatic reserve. If you don't have a reserve, then this is not the appropriate treatment for you. The next one that's actually quite commonly spoken about is the mesorex bypass. And this shunt was first invented, I think, first described in the 1990s. And it was described by a man called Jean Deville de Goyer, who's quite a prominent transplant surgeon. And he actually described it for the treatment of portal vein thrombosis post-transplantation. And it's the only physiological shunt. And it's the only physiological shunt because it's the only shunt that actually restores hepatopetal flow, so flow towards the liver and then through the liver. In order to achieve a successful mesorex bypass, you need to meet a few criteria. The first thing is that you must have no intrinsic liver disease. The second thing is that you need to have a suitable conduit in order to bypass the thrombosis. And the most commonly used one and the most successfully used one is your own internal jugular vein, although you can use non-absorbable prosthetics, although when you use them, then they have a higher risk of thrombosis. And then the last requirement for the shunt to be successful is that you need to have a patent left portal vein. So the left portal vein can't be thrombosed. And certainly in the cases that I've been a part of and the cases that I've seen, the biggest problem that we have is that patients present with this cavernous malformation of the portal vein with the thrombus extending into the left portal vein. And that means that they're not candidates for a mesorex bypass, even if they just have idiopathic extrahepatic portal vein thrombosis, probably because they had an ampulitis or an umbilical vein catheter when they were neonates. It's very interesting. In some of the literature I've read, they've actually described doing the shunts, this mesorex bypass in children as small as 4 kilograms. But certainly I can't say that we have any experience with that. The in-to-side portocaval shunt, the side-to-side portocaval shunt, and the mesocaval graft, whether you use an interposition graft or not, are all examples of non-selective portosystemic shunts. And really the problem with these is that even though they dramatically decrease the portal pressures, you end up with a lot of unwanted metabolites in the systemic circulation, increasing your risk of encephalopathy. The Safe shunt is just another portosystemic shunt, non-selective, where you attempt to maintain some hepatopetal flow by decreasing the diameter of the conduit. And there you see the conduit is a non-absorbable PTFE or Cortex graft. TIPS is another type of shunt, but again, it's something that's only used as a temporizing measure. So it's a transjugular portosystemic shunt. And essentially what you're doing is you're trying to temporize the patient by creating a conduit between the venous and the portal systems. But again, it's not something that you can use as a long stay solution for patients with portal hypertension, just because of the problems of shunt migration, shunt thrombosis. So this is really the encephalopathic bleeding patient that you're trying to bridge to transplantation. And again, in the literature, you do find case reports of patients as young as 1 year that have received these types of interventions. There are several alternatives to shunt procedures, and I think that they were quite prominent in endoscopic management of portal hypertension, and the medical management of portal hypertension didn't really exist. There's various described techniques. I mean, there's the Sugigura, the Hassan, the Hassab, sorry, the Johnston, and the Mathur procedures. But I mean, essentially, they're all trying to achieve one thing, which is stop bleeding from a varix. And what you end up doing is a splenectomy, and essentially transecting the esophagus from the stomach in order to isolate that blood supply. You know, I don't have much experience with these procedures. I have seen one done as an emergency to control bleeding in a patient with portal hypertension, bleeding varices, that was not able to be controlled with Senstaken Blakemore and with optimal medical management. So I can't really comment too much about that. Transplantation is still considered the ultimate shunt procedure, but obviously in an environment like ours, especially in the public sector, transplantation is not readily available. And because it's not readily available, shunt does have some role to play. I would say, you know, I think shunt surgery had an important role to play in the management of patients with portal hypertension when endoscopy and medical management of portal hypertension were not as well developed as they are now. But since we can control bleeding from portal hypertension with banding or sclerosant and with medical management so well these days, shunts are becoming less and less relevant in our current management of these patients. The choice of the shunt that you need to perform depends on, again, what is the cause of the hypertension, what is the anatomy of the portal tree, and what is the patient's hepatic reserve, and also what your own unit experience is. In more developed centers or places where they have specialized units for the management of these patients, they have described shunts in very, very small patients. Like I said, in patients that are the mesorex shunt was described in a patient that was 4 kilograms, and a TIPS procedure in a patient that was 1 kilogram. So certainly the size of the patient is not a contraindication to performing these kinds of operations. If you think about shunts, then just think about them mechanically. The most physiological shunt, the curative shunt, is the mesorex bypass, because you're maintaining 100% hepatopetal flow towards the liver when you've successfully achieved the shunt. The two other types of shunts are either selective or non-selective. In the selective shunt, you're only decompressing a specific compartment. So in the case that we've discussed, it's the Dean Warren shunt, you're decompressing the stomach and the spleen. In doing so, you're decreasing portal pressure, and you're not completely diverting portal flow away from the liver. So you have less issues with hepatic encephalopathy. But with time, these shunts do tend to recentralize, and then you still require some kind of other intervention in order to manage the patient's portal hypertension. Non-selective shunts can either be total or partial, but the disadvantage of these shunts is that you do end up with problems with hepatic encephalopathy, because you're so substantially decreasing the portal pressure by diverting so much flow away from the portal system into the systemic system without going past the liver. We do have a paper out with our experience for shunt surgery. It was published quite a few years ago, 2017. We haven't added too many cases since then. I think it was a series of 10 to 12, and we're probably up to a series of about 14 or 15 in the public sector in our circuit. But if anyone wants to read the paper, then it's freely available on the internet. That's it.
So thank you, Nirav. Thank you so much. I think while I'm waiting for questions, please raise your hand or put it in the chat. I want to just go back to the patient that I started with. And for those of you who joined late, we had a patient with good hepatic reserve, difficult to manage endoscopically varices. He has had a previous bleed. I forgot to mention that. The cause was really an outflow obstruction. He has veno-occlusive disease. So from what I gathered, Nirav, is that this child probably would not qualify for a Dean Warren, so not for a distal splenorenal, because it's outflow obstruction, and therefore just diverting the spleen and the stomach is not going to be enough. Is that what I'm hearing? I know in your diagram, the outflow obstructions went straight to either plant or a non-selective shunt.
I think the patient can qualify because what you want to perform the shunt for is because you want to have more success with your varices, yeah. So by performing the shunt, you will decompress the spleen and you will decompress the stomach and the esophagus. So it is an option for the patient. And then you'd have to look at what's the diameter of the splenic vein, what's the patient's actual hepatic reserve, and see whether it's technically feasible or not. I mean, ultimately, this person needs a liver transplant. Yeah, that's the bottom line for the patient, because even if you compress the stomach and the spleen now by performing a Warren shunt, it will re-centralize, because we haven't changed anything about his intrinsic liver disease. He's only 7 years now, and at some point it's going to happen. I think the decision then is actually, how severe is his bleeding? How difficult is it to control endoscopically? How dangerous for him? Has he actually failed or not? And then if you decide that he has failed medical and endoscopic treatment, because he's having, breakout, he's not controlled on the propranolol, keeps on coming, representing with multiple severe grade 3 varices, then it is worth it to think about Dean Warren shunt, because you don't, by doing that shunt, you don't decrease his suitability for the liver transplant, which is actually what he needs. I think between Prof. Lavla and Prof. Grieve, Dr. Mapunda, there's enough expertise in our centers to offer that kind of service, because we have a relatively large series. The one I told you about were only the ones that were done in public, but obviously far more have been done. Because we have a relatively large series, I think that issues around shunt patency are not like a massive concern. Like you'll be able to get the technical expertise, be able to do a shunt successfully so that it maintains patency. But yeah, I mean, it's just a question of, do you really think that it has failed medical management or not? Yeah.
Thank you. Thanks for explaining that very clearly, I think. I see a question from Ibrahim. Hi, Ibrahim. Hope you're well. And sorry, I've lost your question. Let me just. Thank you for the presentation. Is it possible to go for a liver transplant after the shunt? And I think you did answer that, Nirav, that it really cause too many problems with liver transplantation. So
No,
it's,
when you do if you were going to do a Dean Warren shunt, it's not gonna affect anything. I mean, it shouldn't be an issue.
So I see there's quite a lot of from rural areas as well, or not from South Africa, and access to both endoscopy and ped surgeons might be a problem. So I think we always have this debate on how to manage varices in patients who go back to Polokwane or Mpumalanga, and while overseas, perhaps they can sit and wait for a first variceal. We tend to be quite proactive and scope them and try and ban them before they go back and don't have access to hospital care in a hurry. I don't know what's your experience with that, Nirav. I'm presuming you're also seeing quite a lot of rural referrals.
Yeah, Tim, I think maybe I differ from you there, and I think that's just based on what I've read and what I've practiced. I don't ban them until they've had the first bleed, eh? So yeah, yeah, I don't know if there's a right answer or a wrong answer. I know in most literature people will say, you should have a herald bleed and then band, and not band prophylactically. And then if you have evidence of hypertension, start them on medical management. But they don't live in our
thank Echo New Mexico and Echo India team who do the technical side. To remind you that all our recordings are available on the GastroFoundation website, thanks to the GastroFoundation and thanks to the. And then next week's topic will be
And then the second is a patient that we saw recently who has actually got an abnormal celiac trunk which is draining into the left portal vein. That patient presented with high output cardiac failure and hypogly and some ascites. And I can actually share what we did on the group with you. On the GI WhatsApp group, and you can share it with everyone.
Yes.
It's actually amazing. The patient presented to Barra Peds, admitted to your guys' ward, Dr. Kudu's ward, your ward, Ward 33, with hepatomegaly and a palpable thrill. An ultrasound was done and an echo was done, and I think it was Dr. Mam and his team that did the echo.